Very much, and thanks for inviting me. I'm very happy to present on my favorite topic, am I with non-obstructive coronary disease? So green is go. Let's see. All my disclosures are in kind. All right, it's a case-based presentation. So our case is a 55-year-old woman with hypertension. She was seen the week before her MI presentation and had a blood pressure of 120/90 on 4 drugs, a calcium blocker, ACE inhibitor, thiazide diuretic, and a beta blocker. She just had lipids done. They stink. Her mother had a bypass in her 60s, and she's under a lot of stress. She's a single mother. She's got a son with autism, and she's working as a security guard. She presents to the emergency department after light exertion with 40 minutes of mid-sternal chest discomfort, and she's got a heart rate of 124, blood pressure of 200/126, took all her medications, and her respiratory rate and O2 sat are fine. She's anxious, but she looks fine. Her exam is normal. She's not in heart failure, but her troponin I is substantially elevated. It's 5.1, and that's an old-school troponin. Her D-dimer was negative. She has an ECG done. It shows sinus tachycardia. She has high voltage, as you might expect. And she's developing Q waves in the anterior leads and has hyperacute Ts. Bedside echo is done, and it shows apical hypokinesis, all the apical segments, and Takotsubo syndrome is raised as a potential diagnosis for her. Here's her coronary angiogram. She has mild disease in the right coronary. Here's her left. Circumflex has some bumpiness. You can see there's something going on in the LAD. Before intracoronary nitroglycerin, it looks very different as compared to after. And when we get this other view of the LAD, we see that the spasm that she had is mostly resolved. So she's left with a 30 to 50% set of lesions in her LAD. And it's a wraparound LAD, it's a big vessel. So she has MINOCA. There are standardized diagnostic criteria for this put out by the American Heart Association, and it's really centered on the diagnosis of acute myocardial infarction. Troponin with, in her case, symptoms and EKG changes and a new regional wall motion abnormality, but you don't have to have all of those, just a troponin and symptoms would be fine. And this is somebody with non-obstructive coronary disease. Some of these patients have completely normal coronary arteries. This patient has some atherosclerosis or some residual narrowing, at least we might say. And whenever we talk about MINOCA, we talk about what it isn't. It isn't somebody where you know the alternate diagnosis for the clinical presentation. And I would say in this case, the main differential for her would have been hypertensive urgency because the blood pressure was very elevated when she came in. And I would caution people against attributing troponin to hypertension. I don't think anybody really was doing that in this particular case because the troponin was so elevated. And the EKG was really very suggestive. But in other cases, it may be more of a judgment call. And I would just warn you against thinking that every small troponin in somebody with non-obstructive disease is from hypertension if the blood pressure is really high. Certainly, we have people with occluded coronaries, and we know their blood pressure can get very high. This is a session on MI in women, and MINOCA is a problem that disproportionately affects women. Here are data from just 3 studies, but there are many that show this. This is something that among female MI patients is more common. So looking at patients with ST elevation MI, 4 to 10% of the women have no 50% or greater lesion at angiography, along with 2 to 8% of the men. When looking at non-STEMI, you can just focus on the largest of those studies from ACTION and see that up to 15% of women with non-STEMI have no obstructive coronary disease at angiography. This can also first present as a fatal problem. Conventional risk factors are common among patients with MINOCA. There's less of a risk factor burden than in patients with MI and a higher burden of coronary disease, but there are definitely still risk factors like in this patient. 2/3 have hypertension, about half have dyslipidemia, 20% have diabetes. Most patients have at least one risk factor. And when encountering this syndrome, I think the most common questions that are asked are, was this really a heart attack? What is the treatment? And what is the prognosis? Let's start with the prognosis. It's not great. The major adverse cardiovascular event after MINOCA is high. In the longest-term study from Sweetheart, the 4-year death rate is 13%, recurrent MI in 7%, heart failure hospitalization in 6%. That's a 24% 4-year MACE rate. 2 studies looking at a shorter-term outcome, one from Cath PCI, focused on patients age 65 or older. There's an 18% 1-year MACE rate. And in the largest, with 30,000 patients in a meta-analysis, almost 10% 1-year rate of major adverse cardiovascular events. Now, the outcomes across studies are always better in MINOCA patients than in patients who have MI due to obstructive coronary disease, but they're worse than in patients with no cardiovascular disease, as you might expect for people who are having heart attack. So I hope I've convinced you this is a thing and it's an important problem, but the best treatment of MINOCA is not known. No treatment trials have been performed, or at least completed. So for now, we're using mechanistic and observational data to guide management. Here is everything that causes MINOCA. MINOCA may be due to plaque rupture or plaque erosion. It can be from coronary artery spasm. Rarely it's from dissection, and Dr. Saw very nicely showed you a case that was MINOCA and was in fact dissection, but it's usually an angiographic diagnosis, as you saw in most of her cases. Some of those are thrombosis or thromboembolism, and then we have the overlap syndromes. Takotsubo syndrome, often a diagnostic dilemma, but when you're sure this is neurohormonal stunning, then we would say that it's not MI and therefore it's not MINOCA. There's a differential diagnosis there. And some of the patients proved to have myocarditis. Now, when we listed here, we're not talking about the people that you knew coming in had myocarditis, but instead there are patients who are referred to angiography with the intention to perform PCI. They don't have obstructive disease, and somewhere between 20% and a third of those will prove to have myocarditis on a cardiac MRI. Let's go a little more in depth into plaque rupture and erosion and coronary spasm. Here is the reason that not all plaque rupture or erosion is angiographically evident. So here's a cross-section schematic of a plaque. It has a necrotic core, it has inflammatory cells, smooth muscle cells, and if this ruptures and we get a large thrombus, we're going to recognize this on an angiogram. But if instead we get a small thrombus, that thrombus could embolize, and that could certainly cause an infarct, or we might get superimposed spasm there that can contribute to infarction. When thinking about plaque erosion, the underlying plaque is different, with more smooth muscle and proteoglycans and denudation of the endothelium as the inciting event for thrombosis. But the principle is the same in terms of it not necessarily being angiographically apparent. How common is this? Well, there have been multiple single-center studies that use intracoronary imaging and show that 29 to 38% of patients with MINOCA will have plaque rupture or erosion. We did a multi-center study. Many of the investigators are here on the podium, and we found that there was 43% likelihood of plaque rupture or erosion. This is a lower rate than in STEMI due to obstructive coronary disease, as you might expect, but it's higher than in patients who are asymptomatic and have obstructive disease. And plaque rupture and erosion are not observed in stable patients with ischemia and non-obstructive coronaries. If you first do a cardiac MR and rule out myocarditis or do provocative testing for spasm, you're going to enrich for this as a diagnosis. Now thinking about coronary spasm, which this patient clearly had, if there's spontaneous spasm at cath, it's helpful in making the diagnosis, but you don't always know that that's exactly the cause of the MI. There have been several studies using provocative testing. Somewhere between a quarter and 2/3 will have inducible spasm. That is not always the epicardial spasm, the 90% narrowing in response to provocation. It may instead be microvascular spasm, in which the symptoms and EKG changes are recapitulated, but you don't see that severe narrowing. Spasm and plaque coexist. This is something that's long been observed. And myocardial bridging may actually be a clue to spasm. There was a case series in which acetylcholine testing was done, and often that bridge segment will spasm, or at least that vessel will spasm. Predictors of coronary spasm in this largest series in MINOCA, they're there, and they're statistically important, but diagnostically in our clinical practice, not huge differences here. So younger patients are more likely to have spasm like ours, but men are also more likely to have spasm. You may see ST elevation a little more commonly in spasm, EF may be preserved, but the typical coronary risk factors, while they don't predispose to spasm, they're also not protective. So you still need to think about this diagnosis in people with risk factors. Now, MINOCA is probably multifactorial, and plaque disruption and spasm are probably often happening together, as in this study, in which provocation testing for spasm was done, and then OCT was done of those spasm sites. And you can see that plaque rupture and erosion are fairly commonly observed at the site of spasm. A very recent study that came out is also showing that layered plaque, which is an early healing finding on OCT, is observed at spasm sites. So now we've got our patient, we say her diagnosis is MINOCA, we think we know what the underlying causes can be. What do we do? And you saw this slide from Dr. Mikos earlier. This is from the AHA scientific statement. It's affectionately called the traffic light diagram. And we start with somebody who has a rise and fall of troponin, meets the MI criteria, and then we just pause for a second and say, are we sure this is an MI? Have we thought about pulmonary embolism? Are we making sure this is not a sepsis troponin? And you can usually discard that fairly quickly. And then we have a working diagnosis of MINOCA. And it pays to go back to the angiogram and just sit for a minute and make sure you haven't missed a dissection. Again, as you heard from Dr. Saw, this can be missed, especially the type 2s. Did we miss an embolism? Is there a branch vessel cut off? We do LV function imaging. Do we think this is really Takotsubo syndrome, although you can be fooled? Is it another cardiomyopathy? And we try to get a cardiac MRI to rule out myocarditis, which, as I mentioned, is reasonably common in these patients, although it is not the majority. And with all that done, we're left saying, yep, this is somebody with MINOCA. This is a vascular cause of MI as far as we can tell. And then you may choose to do intracoronary imaging or provocative testing for spasm, or both. But if you don't, or if the studies don't show you anything, then it's called unclassified MINOCA, and this patient is still told that she had an MI. In this particular case, that first angiogram, the patient was taken off the table, but she had recurrent chest pain, and her troponin went to 111. So she came back to the cath lab, and you can see her repeat coronary angiogram on the left here, and you can see the LAD really looks even better than it did when she left with the initial episode. At the bottom here is a normal OCT for reference. And here is the OCT catheter. You see the guide wire making this wedge-shaped shadow. And I think you can appreciate with the lumen cleared out by contrast that you first see an intimal layer, then you see a slightly darker band of media, then the adventitia, and outside that is perivascular tissue. So in this patient, at the site of the white arrow, we get these 3 OCT images that are arranged from distal to proximal. And again, you see here the catheter, the guide wire, and shadow. This asterisk shows us lipidic plaque. If you look sort of at the 9 o'clock zone, you can see that area is normal. But over on the right, from 2 o'clock to, say, 7 o'clock, we see that there is an abnormality there. It's a part of the intima. And we have the smudgy part that light is not getting through. That's plaque. And then closer into that is a new layer of intimal material that the light is getting through. And that separate layer that gets termed as layered plaque. And it sounds like something that's a healing phase and would be old, but this has been observed acutely in MI with obstructive coronary disease and in MINOCA patients. Her cardiac MRI shows an acute LAD territory infarction. I think you can appreciate these white areas of late gadolinium enhancement in the top row. In the anterior wall, anterior septum, the entire apical slice has late gadolinium enhancement. And looking at the T2 weighted images on the bottom, you can see that those areas are bright. This is an acute infarct. Looking at T1 weighted imaging, T1 mapping in this patient, the green areas show increase in extracellular volume from myocardial edema. So again, this is an acute infarct. The layered plaque might make you think this is old news, but this is an acute infarction. We have then followed the ESC, non-ST elevation, ACS guidelines as they pertain to MINOCA. We have a patient with an initial working diagnosis of MINOCA and followed a diagnostic algorithm to differentiate true MI from alternative diagnoses. That diagnostic algorithm in these guidelines looks very much like the AHA algorithm. We did cardiac MRI to make sure it was not myocarditis, which we were not suspecting strongly in this case. And then we managed her according to her final diagnosis of her underlying cause, or in her case, causes. When you don't have a specific underlying cause after your investigation, you use usual secondary prevention for MI. So our case is anterior MI due to plaque disruption and coronary spasm with a reduced EF. She was discharged on enhanced calcium channel blockade, dual antiplatelet therapy for her unstable plaque, ACE inhibitor and beta blocker for her reduced EF, and her EF did improve to 55% in follow-up. So the question was, what should every clinician know about MINOCA? MINOCA is a type of MI that disproportionately affects women. It has a 24% 4-year rate of MACE. There are underlying causes that encompass plaque rupture and erosion, coronary spasm, and more rarely thrombosis alone or dissection. Myocarditis is an alternate cause. It's found on cardiac MRI, and therefore cardiac MRI is recommended in all cases when available. The Takotsubo wall motion pattern has its own differential diagnosis, and this is a point in this case. Initially, it was set up, she probably has Takotsubo syndrome, but that was not the diagnosis here. And we want to try to find underlying causes of MINOCA and treat accordingly. Thank you very much.